Indications to perform a focused cardiac ultrasound include assessment of left ventricular function, assessment for pericardial effusion, assessment for relative chamber size and right heart strain, and a global assessment of the inferior vena cava for volume status. A focus will be done with a low-frequency transducer. Your best choice will be a phased array probe, as it will allow you to look at the heart in between the rib spaces. Alternatively, you may use a curvilinear probe as well. A complete focus will consist of 5 separate views. These include the parasternal long axis, the parasternal short axis, the apical four-chamber, a subxiphoid, and an inferior vena cava view. Step 1. Parasternal long axis. Probe placement will be slightly to the left of the sternum, with the indicator pointing towards the patient's right shoulder. You will then slide or move the probe in small motions in this area to get your ideal PSLA view. Here you will place the probe over the heart, just to the left of the sternum, as you find a good spot in between 2 ribs. Let's take a moment to review normal PSLA anatomy, as seen here with optimal visualization of all important structures. These include the left ventricle, the right ventricle, the aortic outflow tract, the anterior leaflet of the mitral valve, the left atrium, and the descending aorta. On the video clip on the left, there is normal or preserved left ventricular function, which you can note qualitatively by the normal, strong motion of the septal wall and the lateral wall of the left ventricle. In addition, there is good excursion of the anterior leaflet of the mitral valve as it strikes the septum. On the video clip on the right, there is a 4-year-old who presents with cardiogenic heart failure. The myocardium exhibits a feeble or weak squeeze when you compare it to the normal. In addition, there is little to no excursion of the anterior leaflet of the mitral valve, which is consistent with poor or diminished ejection fraction of the left ventricle. The left clip again depicts a normal appearing heart. On the right side of the screen, there is a circumferential pericardial effusion with preserved LV function. Note the arrow points to the effusion collecting to the posterior aspect of the heart on this view. You can use the descending aorta to differentiate whether a large fluid collection is present within the pericardial sac or outside of the pericardium. In these clips, the descending aorta is marked by an asterisk. Note the clip on the left, a large fluid collection is seen to run in front of the descending aorta. In contrast, on the video clip on the right, a large fluid collection is present behind the descending aorta, and this represents a pleural effusion. Again, on the left of the screen is a normal PSLA view, with the left ventricle being the largest chamber that can be seen on the screen. Compare that to the right-sided clip, where there is an enlarged right ventricle and a child with an atrial septal defect. The ASD can be seen to come into view during the early portion of this clip. The RV has compensated and become enlarged due to the constant left to right shunt through the ASD. And finally, in these clips, one can compare the normal cardiac structure that can be observed on the clip on the left. The video clip on the right shows severe diffuse hypertrophic cardiomyopathy. This particular adolescent presented with presyncope during a basketball game, and he had a normal echocardiogram several years prior to this point of care study. Step 2. Parasternal short axis. From your PSLA position, you will rotate the probe so that the indicator is roughly pointing towards the patient's right hip. From the PSLA view, you will rotate the probe 90 degrees counterclockwise. you may need to move slightly down from the mitral valve level to get a good view of the papillary muscles. Let's review normal PSSA anatomy as depicted in this video clip. Important structures to note include the left ventricle, which typically has a rounded or donut appearance, juxtaposed next to the right ventricle, which may appear more oblong or like a croissant. In this view, you should capture the papillary muscles, which appear to bounce up and down on the screen as they work to open and close the mitral valve. Here are two parasternal short axis comparison views. On the left clip, you can see the normal circular appearance of the left ventricle at the papillary muscle level. Note the nice symmetric squeeze and no evidence of pericardial effusion. The clip on the right shows a large pericardial effusion. Although the PSSA view is not the best for smaller effusions, larger effusions can be confirmed on this cardiac window. Note that the large fluid collection is seen to run anterior to the descending aorta, which can be seen here in short axis as it courses behind the heart. Here we can compare the relative chamber sizes in a PSSA view. The normal clip on the left, you can observe the croissant-shaped right ventricle next to the donut-shaped left ventricle. The left ventricle is the larger of the two chambers. The abnormal clip on the right shows an enlarged right ventricle in an infant who was eventually diagnosed with aortic stenosis. The RV here is the bigger of the two chambers. There is also abnormal squeeze and global depression of systolic function on this view. These next set of clips once again compare a normal PSSA chamber evaluation on the left compared to a markedly abnormal appearance of the right ventricle on the right. In this abnormal clip, there is a dreaded D sign with flattening of the intraventricular septum due to a large pulmonary embolus, which has caused increased pressures in the right ventricle and subsequent enlargement. This septal wall flattening is a nonspecific finding and can be caused by any disease process that elevates pressures in the right ventricle and therefore transmits a D-shaped appearance to the left ventricle. Step 3. Apical four-chamber. Here you will remove the probe off the chest and bring it down towards the apex of the heart. This is typically below or near the nipple line, and your indicator will continue to point towards the patient's right side. For this view, you may need to ask your patient to rotate to a left lateral decubitus position to bring the apex of the heart more in line with the axis of your ultrasound beam. Here you will bring the probe up and over to the left side of the chest, where you would expect to find the apex of the heart. Here we can review normal apical four-chamber anatomy. As the name implies, an apical four-chamber view will capture the left ventricle, the right atrium, and the left atrium at the same time. The goal here is to image up through the apex with the intention to also visualize the mitral valve and the tricuspid valve as they open towards the probe and away from the atrial chambers. On this comparison split screen for the apical four-chamber view, the left clip shows a heart with good function. The lateral walls of the left and right ventricle are both seen to squeeze nicely towards the septum. The clip on the right shows abnormal function on this apical four-chamber view of a 2-week-old with a juxtaductal aortic coarctation. This newborn presented with hypothermia, lethargy, and unexplained dyspnea, but had a normal heart rate and blood pressure at the time this focus was performed. There appears to be depressed function and poor squeeze of the ventricular walls. In addition, you can see air bubbles coursing through the right atrium and the right ventricle. You may experience this finding if the focus is performed during IV fluid administration. The other interesting finding here is that there is an occasional air bubble that escapes into the left atrium. This finding is caused by a direct atrial communication, such as would be seen with a small ASD or a PFO. Here we see comparison views again of a normal appearing apical four-chamber view on the left. The video clip on the right is striking for the large fluid collection that is encircling the heart. This large pericardial effusion is starting to show signs of tamponade physiology. The star marks the lateral wall of the right ventricle. This degree of fluid accumulation in the pericardial sac has now overcome the pressures within the right ventricle. This is an important finding to recognize, as inbowing of the lateral wall of the right ventricle is an ominous finding that requires prompt recognition and preparations for pericardiocentesis. In this split screen, you can see on the left normal appearing chamber sizes and a dominant left ventricle, which is the largest of all the chambers on the screen. The abnormal video clip on the right shows an enlarged right ventricle in an adolescent with a pulmonary embolus. There is a greater than 1-to-1 ratio in the size of the right ventricle compared to the left ventricle. This is seen in the presence of right-sided heart strain, which is typically caused by pathology that elevates the pressures in the pulmonary vasculature. Step 4. Subxiphoid. In this view, you will place the probe under the xiphoid process with the indicator pointing towards the patient's right. Using the liver as an acoustic window, you can visualize the heart structures with the right ventricle seen first, located directly behind the liver. In this view, the probe is placed below the xiphoid process. You will likely need to flatten the angle to get under the subcostal margin, and you will look through the liver towards the left side to visualize the cardiac structures. Here we can review normal subxiphoid anatomy in an 8-year-old patient. Typically you will see the liver as the first structure on the top of the screen. Behind this you will see the right ventricle and then the larger left ventricle. This is a great reminder that the heart is oriented diagonally with the apex pointing towards the left side of the body, and therefore the right ventricle is situated anteriorly and directly behind the liver. Here we find comparison views of the subxiphoid window. On the left you see the normal positioning of the heart behind the liver, as we would expect to see on a fast examination. The liver here is used as an acoustic window to get a good view of the cardiac chambers. On the abnormal image on the right of the screen, you see a large pericardial effusion with collapse of the lateral wall of the right ventricle. Although this large effusion appears to be circumferential, the most sensitive place to check for pericardial effusion on the subxiphoid window is between the liver and the right ventricle. This is an example of a small pericardial effusion as seen on subxiphoid view, found anteriorly between the liver and the right ventricle. Step 5. Inferior vena cava. In comparison to the subxiphoid approach, the inferior vena cava view will be obtained just below the xiphoid process, but instead of angling the probe towards the left side of the chest, you will aim the ultrasound beam in a more perpendicular orientation relative to the skin. The simplest approach here would be to start with a short axis view, as the aorta and inferior vena cava can be easily identified next to each other in front of the spine. You can then convert this to a long axis view by slowly rotating your hand in a clockwise fashion to eventually visualize the vena cava completely in its longitudinal axis. In short axis, the inferior vena cava and the aorta are found directly in front of the spine, which is a midline structure with posterior acoustic shadowing. The indicator should point to the right side of the patient, which means the IVC will course closer to the indicator marker. In this planes, the vessels will be imaged in cross-section and will appear as circular structures on the screen. When the IVC is imaged in long axis, the indicator marker will be closer to the right atrium or the head of the patient. Here you can see the IVC behind the liver as it empties directly into the right atrium. So the IVC has been studied in many different manners and many different contexts to see if it can be used as a reliable tool to assess for volume status. To some degree, this is nuanced research that falls beyond the scope of this learning tutorial. However, you can find information you gather from the IVC to be a useful piece of the puzzle, especially when you combine this information with the other cardiac views that you have obtained. Here we find 3 different calibers of the IVC in long axis. On the leftmost video clip, you see a flat IVC, which seems to collapse completely, suggestive of hypovolemia or dehydration. In the middle of the screen, you see a full IVC with some proximal collapse. Clinical correlation is necessary, with particular attention paid to the patient's respiratory dynamics. The clip on the right shows a plump IVC without much collapse seen during inspiration. In the right clinical context, this is suggestive of heart failure and myocardial pump dysfunction. We will now review some imaging pearls, which will include how you might optimize your apical 4-chamber view and the importance of the papillary muscle structure and identification. When performing an apical 4-chamber view, it is often necessary to ask your patient to rotate their body to the left side. This should help you line up the septum down the center of your screen. A high-quality apical 4-chamber view is most important when you want to compare chamber sizes and specifically when assessing for RV enlargement. Here we have 2 patients with large pulmonary embolus and a dreaded D sign on the smaller parasternal short axis videos. The left-sided clip fails to capture the right atrium and the tricuspid valve, and the septum is diving towards the left of the screen, which makes your interpretation of RV enlargement inaccurate. On the right-sided video clip, you can see that the septum has a straighter orientation with good visualization of all 4 chambers and the tricuspid valve, and therefore an accurate determination of right ventricular enlargement can be made. When performing a parasternal short axis view, make sure to find and pay close attention to the papillary muscles. When healthy, they appear like punching gloves working to open and close the mitral valve. If the parasternal short axis view is at the mitral valve or fish mouth level, chamber size evaluation can be misleading, as the shape of the right ventricle can appear larger here. If you see the valves on your PSSA view, all it takes is slight sliding of the probe down towards the apex to get to the papillary muscles. Let's review some potential pitfalls to include the directionality of the aortic outflow tract on the screen and how you might determine if an apical 4-chamber view has been inadvertently flipped 180 degrees. On the parasternal long axis window, many institutions and individuals will image the aorta coursing to the right side of the screen. This is a more conventional orientation for cardiologists. You should be familiar with this distinction and teach yourself to interpret function, effusion, and chamber size assessments with either view. One last caveat to consider on the apical 4-chamber view is the importance of correlating the indicator on the patient to the indicator on the screen. A good anatomical pearl to take away is that the tricuspid valve will generally take off closer to the probe and therefore higher on the screen when compared to the mitral valve. On first glance, the video clip on the right would appear to be that of an abnormally enlarged right ventricle. This clip is actually a result of an operator error. Instead of having the indicator towards the patient right, the probe was flipped 180 degrees and the indicator was towards the patient's left. As you can see, this also flips the image on the screen by 180 degrees, giving off a false impression of enlarged right-sided structures. Since the mitral valve takeoff is lower than that of the tricuspid valve, you can detect that this is likely due to a flipped probe and not due to true right ventricular hypertrophy. A 5-year-old girl presents with weight loss, cough, and difficulty sleeping for several days. On physical exam, there is an elevated respiratory rate, hepatomegaly, and a loud murmur. Electrocardiogram reveals left axis deviation. Vital signs are as shown. How would you interpret the following focus images? Left ventricular function is depressed. There is poor excursion of the anterior leaflet of the mitral valve toward the septum on the PSLA view. Effusion is present. A small pericardial effusion that does not impair cardiac output can be seen on the apical 4-chamber view. On chamber size assessment, there is a markedly dilated left atrium. A plethoric IVC in long axis is shown without collapsibility. Interpretation abnormal focused cardiac ultrasound with depressed LV function, small pericardial effusion, and abnormally dilated left atrium. Follow-up echocardiogram revealed an incompetent mitral valve with severe regurgitation which required surgical repair. In summary, focused cardiac ultrasound aims to gather essential information in patient care situations where clinicians are required to make time-sensitive management decisions. This is a simplified, qualitative, goal-directed, and problem-oriented evaluation of left ventricular cardiac function, pericardial effusion, relative chamber size, and volume status. We have reviewed the necessary steps with imaging techniques and provided interpretation skills to help you perform this crucially important point-of-care ultrasound study.